So bone is white, and you can't see anything beyond it. Your meniscus, we'll be able to see our meniscus today. Nerves, we talk about the honeycomb pattern to your nerve, or a bundle of grapes is the other way we describe those. We're not going to be doing a lot of nerve stuff today, but that's how you identify them on the ultrasound. Vascular structure is obviously really easy to see. Veins and arteries you can pick up. If we flip our patients over today, you can look at the popliteal vessels there. To pick a probe, you're going to select the frequency. There should be people to help you do this. You're going to add gel. Don't add. So professional MMA fighter, he has had a number of knee issues with his right knee. That is his kicking leg. So you'll see this with a lot of fighters. They will put a lot of stress on that knee. And I believe he's had 1 or 2 surgeries. 1, 2. He's had 2 debridements. But he continues to work as a trainer. He continues to train, and he continues to train military members, police forces, security forces in combat training. So he's got to stay active. He told me, I asked him if he had an effusion today, and he said, well, he was just fighting, so I might. So it looks okay though. So it's a good, we're good. I don't have to pull any fluid out of his knee. But he's a typical patient of ours. You know, we want to keep him active, we want to keep him going, and we want to keep him working. So we're gonna do an autologous injection on him today. So I'm gonna step over here so we can start the. And when I said don't put a lot of gel, and then I squeezed a bunch of gel on that. So with the, first turn your machine on, maybe we'll just, so what I'm seeing on my screen is going to be a lot better than when you're seeing up here. The lights are out, but yeah, if you come closer, you're going to be able to see a little bit better. I often start when I'm examining a knee on the superior aspect of the knee, because right away you're going to be able to see if the patient has an effusion. The suprapatellar pouch, you can visualize, which is a little tricky on him, but if I get him to do a quads contraction, we can see a little bit of fluid kind of squeeze up into the pouch. He's also got a bunch of scar tissue up there, typical of a knee that's had a lot of stress on it. You'll see that suprapatellar pouch, it'll get really hypertrophied and thickened. And we can see on this side, his looks like that, just relax already. And you can see your patella, which, you know, he's got some changes on where the quads tendon comes and attaches, a bit of calcification there. I don't think he's got any issues with his quad tendon though, and you'll often pick this up just incidentally. Occasionally you will get a little avulsion there that doesn't get picked up on imaging, but you'll see it on your ultrasound. And the patient will be really tender there. So you can pick these tiny things up. So that's typically where I start, and that's actually where I'm going to do my joint injection, through the supralateral approach, which is where you do an ultrasound guided injection. Just moving to the medial side, we talked about, you saw that picture in my presentation about the medial meniscus. So you can see his medial meniscus, it's a little wedge-shaped structure there. You can also see some lipping, which, you know, is common with osteoarthritis, medial joint line lipping, and you can see his meniscus is pushed out, which is fairly typical. He has had surgery, and this leg has taken a lot of medial stress. You can also see your MCL, which is a little tough to see, but it's this compact fibular structure that runs along the joint, and his meniscus was pushing up against it. Yeah. Sorry. That's his meniscus. I'm just going to slide down, and you can see that MCL come down. He's also got a little bit of fluid coming out around the medial meniscus. Anteriorly, really great for seeing your patellar tendon, and even small patellar tendon tears, patellar tendinopathies, really easy to pick up. It should be this compact, uniform, fibular structure that you see at the top of the screen there. You can point that out. And you can see his patella at the left side of the screen. And you can see that the attachment on the right side of the screen. And this patellar tendon actually looks pretty good. You know, that's what you should see. And you can see half his fat pad deep here. Sorry, were you gonna point? Hyaline cartilage, you can see his trochlear groove. Deep to here, we can maybe add a bit of depth. There we go. Just add a little bit of depth. And you can see his patellar tendon here. And you get a little bit of an idea of how it lines up with that trochlear groove. And you'll see this. Can you just but the advantage of that is it forms like a thick viscous clot that is rich in platelets, rich in, it's actually leukocyte rich. It's we can get about 4% of the cells as stem cells, and then we get the fibrin, which all those regenerative cells sit in that fibrin matrix and get released over a much longer period of time. A traditional PRP gets released over the period of about 7 days. It's fairly quick, whereas the PRF is about three weeks. So what we've done is we've spun it down, we've just separated out the red cells, and we have our plasma layer with all those cells which are currently liquid. So we draw that out of each tube. This is used a lot in Europe in orthopedics for bone procedures. They'll actually allow it to clot, and they will get and they'll pack their whatever bone procedure, even non-unions they'll use it for. But when we're injecting it, we want it to be liquid. So you want to get close to 10 billion. What you can do with this system, you just take more blood. So, so we're going to do, oh, just did that wrong.
How much blood are you taking for this procedure on average?
So each takes, Leah, it's is it 12 that comes out of the, where did she go? It's
okay.
For Robert, one of the challenges with Randy's knee is he's got a lot of, but you might just stick it in that scarred tissue. It's not the end of the world, but it's not going to get into his joint. So what we have to make sure when I'm doing the guided injection is I get into the joint. And as I said, it can be a little tricky. If I stay down here, I got that big blob of scar tissue, and if I slide up a little bit, now it looks a little clearer. And I think I can even see a bit of synovial fluid there. So that's probably a better place to start. So I use the superlateral approach with ultrasound guidance. A little poke here, Randy. What I want to do is I want to get my needle. I want to slide it right into that interface between the quads tendon and the fat pad. And what you're going to see is I'm going to start injecting here. And you can see my tip, so I have to get my needle tip on here. And what you can see is I'm injecting, but you don't see anything coming off that tip. If you do, then I'm not in the joint. I'm just in either loculation or a fat pad, or, yeah, you're a sonographer, right? You always have to do things with it. Oh, and you can see I came out a bit there. So now I'm still in. Okay. So I just put enough freezing in to confirm that I'm in the joint. Thank you. How you doing, Randy?
Good.
Okay, now I'm injecting. Same thing, I look at my tip and I make sure I'm not expanding around the needle tip, because then I know I'm in. Now you're gonna see it, you see it accumulating there. This is it's good volume, right? It's 10 cc's, so you're almost 10 cc's with the xylocaine. So you're gonna see it start to fill, but you don't wanna see it bolusing around your tip. And that's it. And so, thank you. So what we can get Randy to do now, just give him a second.
It's probably over there.
So that'll clot in about 50 seconds. As soon as it gets into the tissue, it's going to really want to clot, and I just leave it a minute to allow it to do that. If Randy gives us a quads contraction, then you see the PRF in his joint. And relax, so his knee is filled, okay? I always do them guided. I know a lot of people do them blind, but I find with a lot of these knees, especially if you get somebody who's had multiple surgeries, it's very easy to stick it in the fat pad, stick it in the scar tissue, get a little locculation there that you're just sticking in the, and your PRF or PRP or whatever you're doing gets, just forms a bolus. If you do that with visco, patients will really hate you. It hurts, especially Durling. If you ever have your patient come back after a visco and they say, "Doc, that was the worst thing ever, it really hurt," it's because you weren't in the joint. You know, you stuck it somewhere else. So that's an injection. So what I would suggest we do is,
Can you just comment
Yep.
before, so what's your aftercare instructions, and when do you know